today I have great pleasure in being able to introduce some real big hitters in abdominal aortic aneurysm management. The presentation tonight is by my great friend Rachel Bell from St Thomas's Hospital in London. So Rachel, thank you very much indeed for the presentation, tips and tricks about open aneurysms. And I've got some real heavy hitters on the panel tonight to give interest and comment. So both Noel Wilson from Canterbury and Mike Wyatt from Newcastle. So I'll just also, for those that are observant, realise I'm clearly not Rick Gibbs, and apologise that Rick has had to go to undertake a vascular emergency. So, but he'll join us later if he can. So without further ado, we're grateful to go to Rachel, and it will share her screen, and we'll go to the webinar of open aneurysms, and also ask that everyone keeps themselves on mute, ask the questions and on the Q&A section, and we'll come back to you either written or we'll answer them live in the question sessions. Rachel, thank you very much.
Thank you very much, Keith. It's a real pleasure to be teaching you this evening on one of my pet topics. It would help if I could move my screen. Yeah, good. Okay, so open abdominal aortic aneurysm repair. I think it's a great operation. It's definitely a team sport. I think it's had particularly bad press, and I would blame the Vascular report from 2007 about that, which briefly said that the UK were pretty bad at aneurysm surgery, and that seemed to lead on to what I have called the endovascular revolution. And my perception is at the moment that open surgery is no longer sexy, and it's perceived as being dangerous. I think we do have to remember that most of the data precedes centralisation of vascular services, and for me that has transformed the way we provide this sort of service. So I have specialist anaesthetists, a great team behind me, a proper pre-assessment, proper pathways, and we do this regularly because we're a high volume centre, and so we're pretty much doing an aneurysm repair a day at St Thomas's. Not all of them are open, obviously, a lot of them are endovascular, but the good thing about that is that it means that your team are on it. They spot the problems, they pick up the complications early. And it will be very interesting to see how the landscape changes following the publication of the NICE guidelines. So for those of you who thought I was just going to talk to you about how you do an aneurysm repair, I just want to brief you on what to expect from this talk. We're actually going to talk about the patient and the surgeon's journey, and that sounds terribly politically correct, but that's essentially what it is. And I think it's worth reminding you all that being a good surgeon isn't just about cutting. And I am going to give you lots of technical tips and tricks, but they're cunningly hidden amongst the many more crucial decisions that you make along the way. And you really do need to know when not to operate, which is sometimes the most difficult decision. You also need to know when you're in over your head, and you need to know when and who to call for when you need help. So I'm going to take you right back to the first time you ever meet the patient. This is a real partnership. The patient has to trust you, so you must be welcoming. I learn a lot from watching the patient walk in through the into the consultation. So, you know, are they sprightly and skipping in, or are they being helped by their daughter? Are they in a wheelchair? These things are really important. And I spend a lot of time in the consultation, well, in the olden days when I was able to see patients face to face, watching for the non-verbal body language, the fear, the terror, the confusion, and I tailor my consultation appropriately. I think it's really important building that relationship. And I mean, I don't need to tell you all to suck eggs, but you do need to take a full history and examine them. There's nothing more embarrassing than getting a patient on an operating table to discover that in fact they had a laparostomy, you know, years ago, and have got a split skin graft as an anterior abdominal wall. That really does change the picture. I do spend some time showing them their CT scans and drawing them some pictures so they understand what I'm talking about. And I really do tell them about all of the treatment options, including doing nothing. And that is a legal requirement now following the 2015 Montgomery ruling. If you don't know about that, go and read it up. It's Montgomery versus Lanarkshire Health Board. And it's worth knowing what your responsibilities are. I always explain my decision making. So if I'm deciding that a patient is going to have open surgery, I'll explain to them why I'm making that decision. And then I will tell them about the operation. And I tend to do the whole truth at this stage, the whole scary truth. And I talk through all the complications. And I'm very explicit about what could happen. But I always try and finish the consultation with some reassurance about how this is, you know, a specialist hospital. I have a specialist team. They will be well looked after. If my dad was going to have an operation, this is where he would have it, because they need to hear that if they're going to go ahead with the operation. And I'm very clear about the plan going forward and who's going to contact them next and what needs to be done before they have their surgery. So this is an important part of this, which is, what do I actually consent them for? So I've written everything on this slide that I talk to them about specifically. I don't think there's anything particularly controversial on this slide, except possibly paraplegia for inferior aneurysm repair is infinitesimally rare, but it's happened to me once in 15 years. It does happen. It shocked the hell out of me when it did happen. It's such a catastrophic complication for the patient. I think it's worth mentioning. I think you have to put it into perspective dependent on what you think the patient risk is. But I think they need to hear it come out of your mouth. So I'm just going to pause there because that's the first little bit, and see if anybody's got any questions about consent and things that they might want to ask me.
Rachel, no one had come up yet on the Q&A, but that point that you were making about leaving them on a positive aspect. I mean, I sometimes try to portray to them that percentage-wise, everything cumulatively, the percentages are of the complications is less than it would be if leaving things alone and they were to run into problems in relation to a rupture. Do you couch it in any particular way?
Yeah, no, I do explain the risk of rupture if you do nothing, and the risk of emergency surgery, and the fact that planned surgery in good hands is definitely the safest way of doing it. I think I very much feed off the patient to a certain extent. Some ask lots of questions, some ask none. Sometimes the wife will ask all the questions, but I will couch it in a way that I hope reassures them but tells them the truth without scaring them witless.
Your approach, if you use it on each occasion, do you use is there a standard? Do you have a standardised consent form?
So really good question. So I'm currently leading the elective surgical recovery at St Thomas's, and part of that, because of COVID, has been to try and develop some electronic consent forms that can be done with the patient at home. And part of the process of developing a specialist consent form means that you have to agree amongst your unit what your complication rates are, what you would consent the patient for, and what is your unit view of what should go on that consent form. And then we are going to standardize the consent forms. I have to say, I think that's a really valuable exercise. And if one good thing comes out of COVID, maybe that'll be it.
On that basis, would you be going to the extent of unit level complication percentages on the consent form? And the other point would be, what about mortality risk? Is that your unit figures, your figures, national figures?
So I think you should have two figures. I think you should have the national figure and your unit's figures. I think that's really important. I'm staying away from individual surgeon outcomes. I think your unit number is very important because it describes a lot about your unit and your team approach. Complication rates, I do a mixture, a range of the unit and national numbers, I think, to give them an overall picture. And I think you do have to tailor it a little bit for the patient because every aneurysm is slightly different. You know, so if you're doing a big aorto biiliac aneurysm repair, your risk of blood loss, retrograde ejaculation, things like that are higher for those operations, and that your mortality actually and your complication rate overall is higher for that sort of operation than it would be for a standard tube graft. So there are some subtleties to the consent.
And one very good question has come when you consent them in the clinic, and I get now it's if we were doing it at the moment, it would be sort of difficult with that first consultation. But for open aneurysms, consenting someone in the clinic, do you sign the form at that same time, or do you keep it to sign at a later date when you go over it again with them?
A bit of a mixture, to be honest with you. So I normally do the first part of the consent verbally. So I talk them all through it, and I'll include it as a paragraph in my letter that I've talked to them about the following risks and explained why. And then maybe not get them to sign a consent form at that stage and let them think about it, and then get them to sign it at a later date.
Great. Thanks. And I've got one more question that's come up online, and I'll see if the panelists had any comments. But since when EVAR came in, we spent a lot of time saying we'd take cases to the MDT, and we're all being in agreement. The open aneurysm cases, would they all go through the MDT, and what sort of discussion would they generate?
Yeah, we take all cases go to the MDT, including open. There is a little bit of technical discussion about people giving opinions about what sort of incision they might make, or whether you think there's going to be a risk of having to clamp, higher than you would normally, so those sort of type 4 approaches and what is the safest way of doing it. But not a huge amount of technical discussion, more of this is an open repair or this would be better. And often the conversations are more philosophical around age and complexity rather than actual technical discussion about the operation.
I might then ask Mike and Noel from if there's any differences in the pathways that they've utilised over time, or have you seen things develop differently in recent years?
Keith, thanks very much. I think one of the most important thing that Rachel has said is that consent is an ongoing process. It's not just dashing in to see the patient the morning of the operation, putting all the known complications down and getting them to sign it without explaining it. And that's a mindset we have to change within surgical society. I'm the same as Rachel. I discuss the complications when they're in the outpatient clinic, when they're first seen and they decide to go ahead. Right. And then go through things, unfortunately, on the morning of the operation rather than the day before because of a day of admission surgery. I'd just like to ask Rachel one question, though. And it was mentioned by one of the panel, one of the participants, with respect to need to ensure that you tell that to the patient, because there is a fine balance between frightening the patient and then exposing them to more risk because they don't undergo surgery, and also encouraging them and allow them to take you on, allow you to take them under your wing and perform their surgery. And Rachel, just going back to your example of paraplegia, I've had one partial paraplegia in an infrarenal aneurysm in 25 years. Now, I don't mention that complication to my infrarenal aneurysm patients. Do you think I'm wrong, and what should others be doing?
No, I don't think you're wrong. And I've had this controversial conversation with many people. I think probably I do it because the vast majority of patients who I'm operating on open are juxtarenal, suprarenal, type 4, where there is a higher risk. I do it for infrarenal because I was burnt by one paraplegic patient in 15 years, a bit like your partial paraplegia. I think I play it down a lot. If it's an infrarenal aneurysm, I'll say there's a really, really small chance because of the blood supply to the spinal cord that sometimes we can interrupt that and there can be problems. But in your case, I would expect it to be very low, and less than 1%. When you talk to lawyers about whether you should mention it, they say you should mention every complication that has a higher rate than 1%. But they say that if you have catastrophic complications that are documented, that you should mention them. I don't know what you think about that. But.
Yeah, I mean, that's certainly for the Aspire 8 course, Rachel, we have the medical director of Capsticks come to speak to us, and that's the direction that he takes us and the trainees with respect to that of aneurysm, and for all operations about that percentage. I do quote or consent people for paraplegia. I explain it. I try not to mumble it when I get to, because it's one of the things at the end, and I'm beginning to get overtly embarrassed about all the terrible things I've told them that might happen at that stage. There's another question, and I'll ask it before we look to move on. But do you feel the need to quote a risk of re-intervention for open repairs to patients?
So I do, but I normally couch it around the risk of graft infection. And I do say that, the graft material lasts for a good period of time, but very occasionally you can form an aneurysm at either end of your graft. And so I talk about, I don't actually quote a reintervention rate, but I do mention that sometimes you have to go back in to do things at a later date, and sometimes quite considerably a longer time after the operation than you would normally consent somebody for, I think.
Excellent. Thank you very much. Should we? I wonder if now's the chance for us to carry on, and we'll take some questions at the next question break.
Sure. Oops. So next bit is about preparation, and I have come from an army background. My father's in the army, and he used to use this phrase a lot. Proper planning and preparation prevents piss poor performance, and I think there's a lot in that. So CT planning. I really do think that planning and 3D reconstruction is not just for endovascular aneurysm repair. I think you need to set some time aside to look at the CT scan. And when I look at a CT scan, I'm trying to make some decisions. I'm trying to make a decision about what incision am I going to make. So you've got a variety of choices. You can go midline, you can go transverse, you can do a rooftop. If you're doing proper thoracoabdominal, there's obviously your thoracolaparotomy option. And then when you've decided what incision you're going to make, you need to think about what type of exposure you're going to have once you get into the abdomen. So might you need a supraceliac clamp at some stage? Do you have to expose the whole of the visceral aorta? Can you just go from the midline? The other thing that I think is really important and can get you into a lot of trouble on the day if you haven't spotted it is, are there any signs of it being an inflammatory aneurysm? There are no doubt that those cases are more difficult, will take you longer, and you might need a friend. Anybody who's ever pulled the bowel out of the way and discovered that someone's literally poured liquid concrete into the back of the retroperitoneum and the whole of the aneurysm, including the iliacs and the renal vein, are just involved in a huge, thick mass of inflammation will realise that this is an important thing to spot before you get into the abdomen. It doesn't stop you wanting to do it or do it. You just have to accept that it's going to take you longer. You will lose more blood, and you might need a friend. I always look at the clamp spaces, particularly at the top and the bottom, and I plan where I think I'm going to put my proximal clamp. Is it above one renal, above both, infrarenal? And I look at the bottom, at the iliacs. Are they really calcified? Will they take a clamp? Might I need to use a balloon occlusion to stop myself from fracturing calcium? Calcium's a really important thing. So looking at how much calcium is in the neck, you don't want to be in theatre suddenly realising that actually you've got a porcelain aorta that you're trying to stitch to. So having a good look at its distribution and what it looks like. I always measure to see what graft I might need. So my rule of thumb is I do a true diameter, and then I'll usually ask for the size down. So if I measure it to be 20, I'll ask for an 18 millimeter graft. And I always decide at that stage whether I'm going to use a tube or a bifurcated, dependent on the appearance of the bifurcation and the iliac arteries. I try and make a decision about whether I might need a Teflon buttress, and we'll talk that through in a bit more detail later on. I like to know if the IMA is patent and how many lumbers there are, because it gives you a bit of warning before you open the sac and you get a lot of bleeding. I specifically look at the things that make it more difficult. So fat patients definitely make it more difficult. I know people have heard me say this before, but it's worth saying again. Omnitrack blades are 15 centimeters long. I always make a measurement from the skin to the aorta, and it gives you an idea of how deep somebody's going to be. I think it's perfectly fine. You can get away with 17 centimeters from skin to aorta if you tilt the blades a little bit. There is no doubt that if they are fatter than that, it is going to be a really tricky operation. Redo laparotomies. I mean, I do redo laparotomies all the time, and I was a general surgical trainee, and meat and drink to get into an adhesion full abdomen. But if you're not used to it, it's worth knowing and think about it. You might need some help. Inflammatory aneurysms, as we've already mentioned, difficult necks and difficult iliacs, and the combination of both of them together make it a tricky operation. I always worry if the SMA is close to a renal. There are several reasons for that. One, if you need to put a suprarenal clamp on, you don't have much space and you can sometimes shutter the origin of the SMA. Also, you find that when that happens, you have less mobility in the tissue over the front of the aorta, so you can't lift it up quite as well. It's quite tethered. And so you get your exposure is often a little bit limited. And again, calcification in the neck. So how do you prep your patient? This is mainly psychological, but I think it's really important to set a date and let the patient know when they're going to have their operation. There's lots of psychology that goes into a patient getting their head in the right place for a big operation. You need to ensure that they've had their pre-assessment, and if you're doing it, prehabilitation. So can they be optimized and be as fit as they possibly can for your operation? I know that vascular surgery is a very unpredictable specialty, and very occasionally we have to move dates of patients' operations because something more urgent has come up. I think it's really important not to be afraid to change the plan if something changes, but you have to communicate well with the patient. You have to remember that they have been sitting at home waiting for this operation and they're anxious. And if you ring yourself and explain why you have to move them and give them another date, I think that's really important. They don't ever want to feel, they should never feel like they've been left and forgotten about. And again, it's about giving them confidence and reassurance that they're in a safe pair of hands and that somebody is caring for them. What about you as a surgeon? So I think it's important for you to set a date and then confirm it with admissions. We've already talked about the MDT discussion, but I think it's worth going back to revisit what was talked about in the MDT to refresh your mind. If you need specific team members, you need to make sure that they're available on the day. Book your HDU bed, check your bloods and your results, make sure that the blood products are ordered. I know it sounds a bit like an SHO's job, but if I'm the surgeon, I feel very responsible that that patient has to be prepped and going on the table with everything sorted. The next item is clear your diary. Now, I have to say that I used to be really, really, really bad at this, and so I used to book meetings in the morning and be rushing around, but I have learnt that actually that's not a good way to prep yourself for a big operation. You need your head in the game and you need to be thinking about it. And now I've stopped doing that. I just put in my diary that I'm in theatre, I go to theatre. And actually it's quite a nice escape from all the other meetings, but I am in theatre thinking about the operation, often teaching the registrar or the SHO how we're going to do it, what I've thought about, and imparting some of that knowledge. It bears saying, although I'm sure that none of you are doing it, don't go out on the piss the night before. You need your head in the game. You want to be fit to operate. And if you need a friend or you think it's going to be tricky, just warn them, say, I'm going to be in theatre. Are you in the hospital? Are you around? Could you come and help if I need you? And then one thing that I have learnt latterly is you need to ask yourself if you're emotionally fit to fly. It's a question they ask pilots before they fly. I just give you one example. I've only been brave enough to do it once, but it was definitely the right thing to do. So I had a patient who'd been in hospital, who I'd done a big operation on the week before, who I'd known for 10 years, who on the morning of my operating list arrested on ITU and died. And they phoned me at 5 a.m. in the morning and said, Dennis has died. And I was very upset. He was a dear patient. I put a lot into doing his operation the week before. I wasn't expecting him to die. And that day I had 2 open aneurysm repairs. And I realised that actually, whilst I could quite happily go to work and do those operations, I wasn't going to be putting those patients' best interests at heart. And I made a really difficult decision to cancel both of the operations on the morning. And I went and I spoke to the patients and I explained why I was doing it. And I booked them for the next week. And I didn't operate that day. I could have done it, but I don't think my concentration levels would have been right. And I think you have to be brave sometimes. It's taken me a long time to realise that that was important. And actually, both of the patients were very appreciative and thanked me for my honesty and were very happy to go home and come back the next week. They can smell fear as well. So I'm going to stop at that point, just see if anybody's got any questions about any of that.
Oh, Rachel, that's an amazing amount of things to talk about. I take my hat off to you about that decision. I hope I make the same one. I completely know what you're saying about that, the feeling of fitness to be able to operate and undertake the procedure, and that gnawing gut feeling. I also think I've taken some points down. I think it's a great tip about the sizing of the skin to the aorta and the blades. We use a Thompson. I think the blades are a little bit longer, but ever so slightly. But certainly they are an increasing challenge the larger patient. I'll go to one question that had come up on the chat, which related to the IMA. That old chestnut of when would you think about reimplanting it? I'll struggle to remember the last time I had to reimplant an IMA, although I have seen ischemia. What would your advice be?
So the whole adage about the IMA, isn't it, is if that it's occluded, then they've got collateral blood supply, so they didn't need it. If it back bleeds, then they've got such good collateral blood supply that they didn't need it, so you don't need it. But we've all seen colonic ischemia. I think I've reimplanted an IMA twice, and that's because on table it was very obvious, despite a hemodynamically stable patient, the colon looked very grey. And I think you have to act on what you see. Sometimes I've regretted not doing it when I've had to take them back on day 2 because they've got ischemic bowel. But I talk about it a bit later on about what to do if your colon's looking dodgy and what your options are. So I'll save it for then.
Excellent. I might ask the panelists as well. Noel, your IMA experiences?
Yes, no, I mean, as Rachel's alluded to, I mean, the kind of theory as to how to approach it, I have to say I've only ever once implanted an IMA, and I probably didn't need to. Otherwise, it is routinely either ignored if it's not back bleeding, or it's treated as a lumbar and oversewn if it's back bleeding. And the occasions where one sees colon ischemia has no bearing on whether or not that IMA was patent or not.
My main reason for looking for it on the CT scan preoperatively is to remind myself that something else other than a lumbar might back bleed. And sometimes it does bleed quite a lot, and often doesn't bleed until the end when you've reperfused everything, and then you wonder where all this blood's coming from. So it's just worth knowing whether it's patent or not.
One of those contentious questions that comes up, Rachel, is whether or not an open aneurysm is a two-consultant operation planned from the start or not. You commented about that aspect of phoning a friend, but I suspect the answer really relates to who's in the team and how the team best functions. But where do you stand on that dual consultant operating?
So I would happily do an open infrarenal aneurysm on my own with the registrar. Really don't have a problem with that. I think when the complexity ups a bit or something goes wrong during the operation, I am the first person to ask for help, particularly if you're a bit tired. But if you're doing a suprarenal aneurysm repair or type 4, I think you really benefit from having an experienced operator in theatre. The patient does, and it definitely halves the stress for you. I think there are questions about training for that. I have to say that if we are doing dual consultant operating, we plan the operation and the trainees always get to do part of it, even if they're doing the top anastomosis. I've got no problem with them doing it. We always allow them to do bits, but sometimes actually the dissection is the most difficult thing, particularly for me when I'm doing lots of redo surgery. Once you've got it dissected out, stitching the top and the bottom in actually is the easiest bit. It's the dissection for redos that I like having someone else around for. If you have massive bleeding from a renal vein or a gonadal, it's very helpful to have somebody who knows what they're doing in theatre. And I think we all have to remember that we're here for the patients. I mean, as much as surgery is great fun for the surgeons, we have to put the patients first. I'm doing more and more dual consultant operating, but I think that's partly due to my practice. So it's lots of explants and redo at aortas, which I think it is quite useful having somebody else in theatre. But for a standard primary first time in infrarenal aneurysm repair, happily do it on my own.
Excellent. Mike, I was going to ask how you've evolved that over time.
Yes, I mean, to be honest, most of our infrarenal aneurysms are training operations, and a consultant would do them with a registrar or a couple of registrars. And a lot of my time now is spent watching the registrars and guiding the registrars, scrubbed up in what they do. Nevertheless, if you have a complex case or a redo case, or as Rachel said, a case where you expect bleeding, to have a second consultant immediately halves the stress. As soon as you have somebody else there, you relax and you do it together, no matter how difficult it is, and you can also have breaks. And so anything complex, and Rachel, you're quite right, the type 4s and the more complex thoracoabdominals, it is so important to have at least 2 surgeons, and we quite often have a cardiothoracic surgeon as well, if the patient is on bypass. But for straightforward, simple infrarenal, it's usually as consultant and 1 or 2 registrars as a training operation.
Excellent, Mike. Thanks very much. And I was, I'll have one more question and then to move on, and I'll cover the rest of it later. But incision-wise, Rachel, I think when we were training, we worked for exponents of midline and then transverse incisions. I think I've evolved to be horses for courses. Where do you stand on the incision? Are you the same every time, or? I'd
probably say I do about 85% of mine through a midline. Can do a lot through a midline. If I'm at all concerned that I might need to go higher, I will use a rooftop. I think a rooftop's really useful if you need celiac, a supraceliac clamp. You can do a supraceliac clamp through a midline. You can if they're a thin patient. And actually a rooftop gives you all the exposure that you need. You can get to the iliacs, you can do the same operation from the front. It just gives you an option from going from the back. I very rarely do a transverse now, although when I first started as a consultant, I did lots of my straightforward infrarenal aneurysms through a transverse incision. I thought the patients definitely seemed to have less pain and got out of hospital quicker. But I've pretty much reverted to doing mostly midline.
And Rach, can I ask, has that changed at all with the redos and the explants, the infected cases that you've been taking on?
Again, pretty much do most of them through a midline, but some of them through a rooftop if they're going to be really difficult. Getting a stent graft out with suprarenal cage, sometimes it's really useful to have access to the supraceliac aorta, because you can get them out from below. Sometimes it's easier just to lift them out of the aorta rather than tug them out.
But you never say plan from the start to go to a more classic, say, retroperitoneal approach, or
so I would say I do thoracolapprotomies, obviously, for primary thoracoabdominal aneurysms, for type 1s, 2s and 3s. For type 4s, I would say I do the vast majority with medial visceral rotation through a rooftop. I have done thoracolapprotomies, and for those, I tend to only do that when I think I cannot clamp the aorta in the abdomen. When I have to go into the chest to clamp it, then I'll do a thoracolapprotomy. There's no doubt that the morbidity from a thoracolapprotomy incision is much higher than that of a rooftop. It's that cutting the costal cartilage. They get a lot of pain post-operatively. I've tried all sorts of ways of stitching that up to stop it. It's because it doesn't really heal and it moves a lot, and they get a lot of chronic pain. I've even tried cutting it out altogether. But it gets quite a lot of hernias. You're going through quite a weak part of the abdominal wall, so it's not a great incision for the patient. It's a great incision for the operator because you get the best exposure. I mean, nobody ever died of an incision, as one of my colleagues used to say, that it is one of the biggest incisions you can possibly make on a human being. But it does have morbidity.
Great. Brilliant. Thank you very much. I'll come to the other questions towards the end, Rachel, if you want to carry on.
So on to the meat and drink of the prep, and now some technical tips and tricks. So on the morning of the operation, I always go and see the patient. I try and be as kind and reassuring as possible. I try not to say frightening things. You should have done that before. I make sure the patients know the order of play and how long things really take. Because often, you do a set of Bains in the morning and you say to them, oh, it takes 20 minutes. But in fact, with all the theatre faff on either side, it takes more like an hour and a bit, and they're panicking, waiting for them to be called to theatre. And I always take the telephone number of a member of the family, so I phone at the end of the operation, and it's really good practice. We all do WHO team brief nowadays, and I think it's really important that you tell your team what you're planning on doing. You tell them about plan A, but also potentially plan B and C if you think it's going to be difficult. And as a surgeon, I think you need to verbalise your Christmas list of what you want in theatre. So I tend to just want a decent pair of scissors and a pair of forceps, but I have a lovely colleague, Mr. Salam, who does like an array of stuff on a table next to him. He rarely uses it, but he likes having it in theatre. It's like a security blanket. So what's my get out of trouble pack? So definitely Teflon. I love Teflon, so I use the Teflon strips to buttress the aorta, and I like these little soft pledgets. They come in lots of different forms, but the soft Teflon is the best. Cardiothoracics have it in big sheets. Often the nurses get out those little sort of pellet-like Teflons that are more like sort of after dinner mints than they are Teflon pledgets. You want something that's malleable, that will form to the aorta. I like a metal sucker without the guard, and I normally have two without a guard, and I use them often in the redo cases to do quite a lot of the dissection, and I use them to make sure I'm down the side of the aorta. I think they're really useful. People think I'm crazy, but I like them. I like a Glover's clamp. That's my favourite aortic clamp of all time. Find your favourite aortic clamp and use it and know what it does. You need a... Ooh, where did he go? Come back. You need a great anaesthetist. So I know he's got a badge on that says nurse in charge, but this is Dan Taylor, and he has got me out of more trouble in theatre than any equipment ever has. You need someone you trust. Very occasionally, I don't use 2O proline for the top anastomosis. I normally use 3O. But when you've got a really rigid or horrible aorta, sometimes the benefit of a 2O needle, it's big, it's strong, it will take big bites through horrible tissue, and it can get you out of trouble. I've already mentioned this, but silastic urinary catheters, using as balloon clamps for iliacs, very occasionally the aorta if you're in real trouble. I prefer the silastic ones to the latex ones because they've got more strength, longitudinal columnar strength. They tend to stay where you put them. The advantage of these, if you put them down an iliac, so if you blow them up with water and secure them in place, you can flush the iliac through the other port using a 50 ml syringe. It's quite nice for making sure that you've got good heparinization and flushing of your iliacs. A nerve hook, love a nerve hook. If you've got a loose anastomosis there, you need one of those and I'll show you how to tighten that in a minute. Dardek clamps I like because they've got nice soft blades and they tend to cause less damage in highly calcified iliacs. And then you need a pal, and Morad is my pal. If I'm in trouble, I will call him. So operation sequence. So people do this in different ways. This is my way, find your way. So I do an incision and I always do a laparotomy. I think to date, I've found 8 bowel cancers from doing a laparotomy. Not big ones, not something that you would have necessarily been an error to miss on a CT scan, but small lumps in the sigmoid, transverse colon, cecum. I've always gone on and done the operation, but then got a GI surgeon in to have a look, and then they've been scoped and treated. It's really worth it. It gives you an idea of what you're dealing with. I use an Omnitract, and I'm going to show you how I use it for packing and exposure in a minute. The first thing I do with dissection is I dissect the iliacs, and I do it and I just put some swabs where I've dissected out my clamp space. And the reason I do that is I then want to concentrate purely on the neck. And when you use the Omnitract and you get a really good dissection of the top and you've got really good exposure, if you do that first and you haven't done your iliac dissection, you often then release your Omnitract. You get everything falls in. You lose your view of the top end. You do the iliacs, and you never always get that really great exposure the second time round because everything's a bit more swollen when you go back to put your retractors in. I dissect the duodenum off the aneurysm very carefully and move it away because I personally think, and we'll come back to this, that the duodenum is full of evil when it comes to an aneurysm repair. I then do the top end and get my proximal clamp space, select my graft, clamp top and bottom, open the sac, deal with the lumbers and the IMA. I don't think it matters what you deal with them with. Sometimes some people use proline, some people use Ethibond, but stop them bleeding. Beware that in patients with lots of lumbers, you can lose a lot of blood quite quickly when you open the aneurysm sacs. You need to be prepared and be on it. I then do my proximal anastomosis, distal anastomosis, make sure that everything's dry, and then I close the sac, and then I close the abdomen. And I'm going to go through some other bits now. So I always use the 3 wet rolled swab trick. So 3 wet rolled swabs, and then I set it up like this. So you put one of your rolled swabs down over the sigmoid colon and push it away. Your second one up over the omentum and the transverse colon and push it up and away. And then your third one, if you've got a big patient, you can put it up in the sort of right upper quadrant, but sometimes I just unroll it and use it to pack the bowel away. I try and put the bowel inside, so I tuck it up and squeeze it inside after I've done the duodenal dissection, because I think the bowel is better off inside the abdomen than hanging over the edge of the patient and getting edematous. And that's pretty much how I set up the omnitract. So I think the renal retractor, which is the one at the top, is very useful for scooting underneath the renal vein and lifting it up so that you get a good view of the neck. And you get a very good stable position, and you can really get a good view of the retroperitoneum. And I think having skills with the omnitract or whatever retractor you use is really important. There's some real subtlety to the mechanics of how you set it up and how you pull all the tissue away so that you get a great view. And it's worth practicing. So proximal anastomosis, how can you do it? So I don't really mind how you do it. So I've seen people do it all sorts of ways. You can stitch down the aorta, which is the way I do it. You can stitch up the aorta, which is easier sometimes in some patients. You can tie down your graft in the middle and stitch it either way. You can parachute it, as like the diagram. Some people like to transect their aorta, which is sometimes a good thing to do if you've got a really dodgy top end to do, because you can see all the way around. My advice is take big, sensible stitches, even big stitches. And I always try and tie my knot to the left side of the aorta away from the duodenum. I've done too much redo surgery now, and I see lots of things that are all related to the duodenum, where, you know, suture material is eroded or caught in the wall and started off an aortoduodenal fistula. Cutting the graft. So one of my things is the scariest things in vascular surgery, according to me, so nobody else, is cutting grafts. So I think you can get into a lot of trouble cutting grafts, and tunneling grafts scares the living bejesus out of me. But the most important thing in aortic surgery is don't cut your graft too long. So I've drawn a quick picture underneath, which is when you cut your graft too long, it bows up. And the problem with that is it really does put pressure on the duodenum when you've closed it. And if you get a big bow, you can see where it rubs on the duodenum repeatedly. So really try and cut it snugly. So not too tight, but not too long. And as my job at the moment is to take out people's infected grafts, I see more than my fair share of aortoduodenal fistulae, and they kill patients. And so taking a bit of care the first time out, I think, is worth a thought. So don't do that. I'm going to pause at that stage. Anybody's got any questions?
That's fantastic. It's a great slide, Rachel, with your setup, and it made me smile. The three swabs. I remember where that may have evolved from. But so can I ask Mike and Noel sequentially whether or not is there anything that they might do differently, or any subtleties that they have evolved over time? Certainly, it's an experience thing to know how it's best to set it up. Coming to Mike first.
Yeah, I think we both trained at Mary's and probably do things fairly similarly, including those three swabs, which are really magic tricks, aren't they? They get the all out of the way. I agree with you, you should keep the bowel in, but if it's in the way, don't be frightened to hang it out. I also think that we need to be very aware of the damage we're doing to the bowel when we're focusing on the aorta. And I've seen occasions where you do the top end and it's brilliant, and you go down to do the distal end and you don't release those renal clamps, and you put pressure on the SMA. And then when you look at the bowel in the bag or in the abdomen, it looks absolutely ghastly. So if you're doing the top end and you've finished, take the pressure off the SMA, take the pressure off a bowel bag if it's hanging over the side, let the bowel recover, or if it's inside, just make sure that you're not, it's not too ischemic, and then go on to the bottom end. With respect to the top end, the anterior spinal ligament is fantastic. If you really want to get a good bite on a poor top end, as Rachel said, put really deep sutures in and use that spinal ligament. It'll help you. Also, be aware of the left retroaortic renal vein. I've got into damage with that a few times, and always look for it on your pre-operative CT scan. I always tell my trainees, if you're in trouble, don't be afraid to use a supraceliac clamp. Sometimes it allows you to correct the situation, especially when you've got a really large aneurysm, and also possibly if you've got a rupture. But that is your point of get out, and it's so easy just to pop it on from the front between the crura. Rachel mentioned the pledgets. They're brilliant. I quite often cut the bottom end off a graft to save money and make them into my own little pledgets, which seem to work well.
Is that what you're going to make me do when I come to Newcastle, Mike?
Yeah, we don't have as much money as you do down at Tommy's, but if you just bring a couple of packs up, please, we'll be absolutely
okay,
fine.
Done.
I occasionally, if I'm in trouble, transect the aorta and use a cuff of the graft around the aorta to seal it. I use tissue glue occasionally, but not often. But if I've got a really ragged aorta, I occasionally will just clamp everything off, put some tissue glue on, put some pledgets, and watch and wait. And sometimes you get a good result from that.
That's brilliant, Mike. Thanks very much. Noel, what about yourself?
Yeah, I think we all have had similar training programs, so that a lot of the techniques are very similar. But I would absolutely reinforce, firstly, being absolutely familiar with an Omnitract and how to use it properly, and making certain that your blades are at the right angles. All too often I've seen people put particularly blades when they're dissecting the top end and displaying the top end, invariably they use the renal vein retractors, and they are never at 90 degrees. And if you angle a renal vein blade, it's a real problem. So being very familiar and having a reproducible system for your Omnitract is crucial. I always keep my bowel in, but I agree with Mike, at the end of the day, if access requires, you do the needful. We haven't talked much about clamping in the sense of whether it stays infrarenal or actually, for the sake of getting the right length of neck, we do a suprarenal clamp. And I have to say, I have no qualms about being prepared to do a suprarenal clamp for what is perceived to be an infrarenal aortic aneurysm. Because, as was suggested before, it's all too easy to misinterpret. If one doesn't plan carefully, actually this neck is pretty tatty. It's got thrombus in it, there may be calcified plaques, and it's not as good a neck as we might have perceived. So I have no qualms about displaying the neck at and above the level of the renals to make sure I've got the access there and then. You do not want to have to be suddenly thinking, oh my goodness, I do need to move it up, and I haven't really prepared myself.
No, since you mentioned that about the clamping, hand in glove with that always goes to what you do about the left renal vein.
Yep.
So can I ask what your views are on ligating, transecting the renal vein, or just do you tend to try and retract it?
So yeah, I think that's a really good point, one I've jotted down here. So the left renal vein, invariably, I immobilize and I can keep intact. I think I've divided it a couple of times, but most of the time you can move it. The thing that will tether it, of course, is the gonadal vein. And I know there are people that will say, well, if you divide the gonadal vein and then you're faced with dividing the left renal vein, perhaps you've reduced the opportunity for venous outflow of the kidney. I'm not sure personally that's true. So I would, if I need to, default to dividing the gonadal vein, because the last thing you want is that bleeding. That's a horror to try and chase if it retracts. And you can get a good idea from your neck dissection and using a Wiley retractor on the renal vein to see how much it's safely going to retract to allow you to display the neck, and that includes suprarenal. So my approach would be to dissect out the left renal vein, assess where the gonadal vein is, and or whether there are any smaller branches posteriorly, often which they are, and by default divide those, so I allow further retraction of the left renal vein up, and that's how I approach it.
Excellent, thanks very much. Rachel, what are your thoughts on the left renal vein?
So I'm pretty much with Noel on that. I very rarely transect it, but I think in those aortic necks where the aorta's coming out towards you and is tenting up the left renal vein. Sometimes it's very difficult to get under it safely and lift it up. And sometimes I make a decision almost before I've gone into the abdomen that I'll probably sacrifice it. I agree that it's normally the gonadal that causes the problem, and it's normally you evulsing the gonadal off, which it causes great problems. I'm going to show you some slides in a minute where that's happened in the past. So I try and keep it in situ if I can, but I don't mind dividing it if I have to. It's not something that scares me. I think you just have to do it safely. Do it between 2 clamps and oversew both ends.
And can I ask? I'm going to smile answering this question because it's a real. I can remember thinking about it as a trainee and certainly going through when I started as a consultant. But where do you stand? Which side of the table do you stand on, Rachel?
Either. So normally I stand on my preferred side is the right, but if depends which way the aorta is going, very happily operate from the left too. And actually I make a decision based on what it looks like and where is the easiest place to stand. And I think as a trainee you get fixated about the side of the table. I think you should move if it's ergonomically not working for you, move to the other side.
I'm so pleased you said that. The smile was the thought that there was very much a teaching. I only do it this way, and it seems to evolve the left. And I always find that the left side was somewhere to go to when it wasn't comfortable on the right. But that's where I start. And before moving on, one of the participants has asked about loops for aortic surgery and whether or not we utilise them. I must say I do use loops on occasion. In fact, most of the time. But that was working for Thompson sort of thing. So we wore them all the time, and I got used to it. What about yourself, Rachel?
I don't use loops for aortic surgery. I like the aorta because it's big and I can see it. I don't need loops. No, I don't wear loops for aortic surgery.
The other reason I would say that I've remained using loops is because I haven't quite got used to the art of operating with varifocals. So
Yes.
It leads to more predictable. So I'll ask you to move on or to carry on if that's all right, Rachel. We'll answer some questions towards the end. I've got a little question from Patrick to come up later as well.
Okay, so just a brief some tricks or things that you can do when things go really wrong. So I've listed the things that frequently go wrong or can go wrong. So your top end falls apart, you have massive venous bleeding like we were just talking about, you have concerns about a blood supply to a kidney after you've done your top anastomosis, the colon looks a bit grey, you've got iliac vein bleeding, you've got that terrible moment of lifting back the drapes when you've done a long operation to discover that one or both of the feet are white, and a bowel injury getting in or out of the abdomen. So what do you do if you get into trouble? So I think the biggest trick is to keep calm, communicate, phone a friend if you need one, and if you have to pause and make another plan, don't be frightened to do that. Just talk to everybody in theatre. So I always speak to my anaesthetist. He's normally on it because he's heard the sucker going or he's realised that something's not quite right, and I will call a friend, as I keep saying. So what about the top end? I think a lot about the top end is predicting that there's going to be a problem and changing your initial plan as if you're concerned about the quality of aortic tissue that you see. And I would really strongly advise for you to use your eyes, loops or not, and your fingers to tell you things that the CT can't. And it may be that on feeling the neck, you make a decision to go higher with your dissection so that you can clamp higher and stitch to better quality tissue. It may be that you make a decision to use a Teflon buttress for the whole anastomosis from the start because you're worried about the fragility of the aorta. You can, as Mike said, consider transecting the aorta, which sometimes does help. I think if you're aware that the wall is really fragile, you have to be really careful with your needle handling skills and follow the curve of the needle and Be very gentle when you're stitching. And I sometimes use, if I'm not going to Teflon buttress it, I sometimes use preemptive Teflon pledgets to reinforce the wall when you put your needle through and it feels like you've put it through nothing. And you think, my God, this has got to hold an anastomosis for another 10 years and it feels like I've just stitched to fresh air. I always, and I think this is a great tip, and Pete Taylor taught me this, is I always fill the graft with saline prior to taking the clamp off, because you get a clue as to whether your anastomosis is a disaster, and you lose water rather than blood, and you can fix some of it before you take the clamp off. So I've just drawn, this was me sketching a picture, so apologies. This is me putting a Teflon buttress on. So if I've decided that I'm going to put a Teflon buttress on, I think you need to set it up right. So you have a strip of Teflon and you have your stitch, and I go graft, Teflon, aorta, Teflon graft, Teflon aorta, and you have to talk to yourself when you do it, and you need a good assistant, because you can get very confused and you can go in all sorts of places and end up with a dog's dinner of a cat's cradle. But what's really nice is you can get the Teflon to go circumferentially around the anastomosis. If you've got a fragile aortic wall, or you know you're doing a connective tissue disease patient, I think it's really worth spending the time. What do you do if you've got lots of bleeding? Well, the commonest cause for lots of bleeding is a loose suture line. I've drawn these pictures to try and illustrate how you fix that. I'm sure you've seen it all done, but you basically find a suture that looks loose and you use a nerve hook to lift it up. And then you feed your new 3O proline through that loop and pull up on it. And then you put a stitch adjacent to that loop and then tie them together and tighten your suture line. And sometimes that is just the magic you need to stop the bleeding. It's a great tip. And if you haven't seen it done, get someone to show you how to do it. The other thing you see a lot in fragile aortic wall is where you've taken a slightly deeper suture than you have for the rest of the anastomosis, and you've got a longitudinal slit in the wall of the aorta. Those slits are really difficult to mend if you try and do it conventionally by putting more stitches in. You need to recognize that it's a longitudinal slit, and I normally try and mattress 2 Teflon pledgets together to support the wall, and I go horizontally across the aorta. You're unlikely to narrow it. It's a huge blood vessel, but it will give you a nice hemostatic closure. Renal vein bleeding, well, we've sort of talked about this in quite some depth, but this is the patient that I did last week for an explant, and this was his preoperative CT scan, and you can see that it looks like he's been shot with a Liga clip gun. There are millions of Liga clips in the region of the renal vein, which look secluded. I agree with Noel that it's often not the renal vein that bleeds. It's normally the avulsed gonadal, often on the left-hand side, and you just get massive bleeding from the side of the aorta and you can't see it. It's incredibly difficult to control, and you often lose lots of blood very quickly. Venous bleeding is much scarier than arterial bleeding in my experience. You need to warn your anaesthetist. You need a cell saver. I'd get a friend to come and help you, and you have to use compression to control the Brits. You can, and stitch or use Liga clips to close it. Possibly not this number of Liga clips, because actually the cause of this patient's aortoduodenal fistula was a Liga clip that had eroded into the aorta, and you can see why, because there are so many of them there. I think in this particular complication, an experienced assistant is invaluable. IMA, we talked about this briefly before. So what happens if you look at the colon just as you're closing and it looks a bit dodgy? What do you do? So you can reimplant the IMA. It looks like that's a very unusual thing to do from my compatriots on the panel. Normally what I say is, let's get the patient off the table, warm and fill them in HDU, and watch them very closely, and have a very low threshold for going back to theatre. I think if you go for option 2, communication's the key. You have to write it in the operation note, tell the staff on HDU, tell your colleague on call, tell the registrar, because what you don't want, which I see so much nowadays, is that they're a bit dodgy, and someone sends them for a CT scan, and then their renal function goes off a bit and nobody reopens their abdomen. I have a very low threshold for unzipping them and having a look. I'd rather do that than wait for them for their colon to perforate. White foot. What are the causes of white feet? So clot in the leg, trash in the foot, chronic peripheral vascular disease, or a technical problem with your anastomosis is obviously a possibility. My golden rules of thumb are, if you've got a good femoral pulse, but you've still got a white foot, cut down on the groin and do an embolectomy. It allows you to check the inflow and do a better embolectomy on the leg. If you've got a good femoral and popliteal pulse, it could be trash in the foot, but I think it's still worth doing a femoral embolectomy as a cut down from the groin. If you've got poor or no iliac pulse, then you've got to assume that it's technical, probably related to your anastomosis. You can do a graftotomy at the bottom and try and pass an embolectomy catheter down. I find that doesn't work very often, I have to say. You can consider redoing your distal anastomosis if it's technical and origin related, but I worry about that. And if the origin's okay and you can't pass your catheter, then I just jump them to the groin. I think the big rule about vascular surgery is don't fool yourself. Vascular surgery is unforgiving and you normally get instant success or failure. That's why we all like it. It's not colorectal surgery. You don't have to wait 5 days for your anastomosis to leak. You can see it in front of you. But I think when you're tired, you can fool yourself, and so don't fool yourself. If it's not right, don't take the patient off the table. If you're tired and you think you're making a decision to stop because you need a cup of tea and a sit down, phone a friend. You won't regret it. So I'm going to pause at that point.
Rach, thanks. That's fantastic. Can I? You talked about venous bleeding, obviously it being much worse than arterial. Any specific tips for the management of an aorta cave or fistula? I know ideally one identifies it's going to be there beforehand, but when it does appear intraoperatively, how do you go about managing that?
Yeah, so I get 2 swabs on sticks, and if I find a big hole and it massively bleeds, you can normally identify. To be honest with you, you should have identified it before you got to the aorta, because you often get massive venous bleeding just going through the skin because of all the hyped up pressure in the venous system. But when you actually are in the aortic sac, I use 2 swabs on sticks on either side, and then I just run a big suture up the inside of the aortic sac. Done.
Excellent. Thank you very much. And I have another question related to suprarenal clamping and potential for reimplantation of the renal arteries, or suprarenal clamping and protection, let's say, of the renal arteries. What sort of time are you happy having a suprarenal clamp on and not affecting renal function?
So I think with warm ischemia time, if you have a suprarenal clamp and it's not compromising the SMA, I think you're probably all right for, I don't know, 30 to 40 minutes. You've got a decent amount of time. I don't think there's any need to rush, particularly for normal renal function to start with. They will get a bit of a renal hit post-operatively, but normally you can do it in much shorter times than that. I mean, I would try and get a top end in 20 minutes in that situation if it was complicated. And I think that's very reasonable. If you've got a supraceliac clamp on, that's a slightly different game. I would definitely try and keep your clamp time down to 20 minutes at max.
Excellent. Thanks very much. I was going to go to Mike and Noel. If there's you had anything else you wanted to say about clamping, specifically suprarenal?
Yes, I agree with Rachel. Try and get a suprarenal and supraceliac clamp anastomosis below that in 20 minutes if possible. But I think you've got up to 40. I think that's correct. With respect to the dissection, iliac veins matter. It's really, really important. And sometimes you finish the top anastomosis, you go down to the iliacs, and you hit an iliac vein or an IVC, and all hell lets loose. And it's really important not to relax once you've got a dodgy top end off. And most of the problems I've had relate to iliac veins and IVCs rather than arterial bleeding. And I've had 2 on-table deaths over the years from elective infrarenal aneurysm. Well, no, one was a type 4, from elective aneurysms from iliac vein bleeding. And one of those was a connective tissue disorder, a Marfan's, where the iliac vein just fell to pieces and the IVC. In both those cases, I've called a friend, called for help, but to no avail. And one of the little tricks I have is to try and clamp the 4 iliac arteries rather than clamp too near to the aortic bifurcation. That keeps you away from the sympathetic nerves, and it also keeps you away from the left common iliac vein. And it quite often gets you out of trouble. A nice little memory tool for venous bleeding is lamps. You need light, you need manpower, you need access, and if the incision's too low, just make it bigger. Whenever you call the liver surgeons in for bleeding, they always make a bloody big hole. You've got to up and down, they do a transverse. If you've got a transverse, they do an up or down. Access is so important, manpower, pressure, and sutures. And as Rachel says, if you have venous bleeding, put pressure on it and think. Get help, get light, make sure you can see, and make sure you've got enough access. We use cell saver for all infrarenal aortas as routine now. You never know the one that you're going to get a big bleed. With respect to calcified necks, I still use a little towel clip. And sometimes you just can't get a needle through it, and you need something that's going to crack the calcium. And I quite often have one of the little sharp towel clips that aren't allowed anymore, but we can usually find one. And for a patient who's not doing after an operation, go ugly early, do the negative laparotomy, do what's safe for the patient. Nobody minds if it's a negative laparotomy. If you've got to worry about colonic ischemia, have a look and see before that colonic ischemia takes that patient down. I think that's about it, Keith.
That's brilliant, Mike. Thanks very much. One of the little men in my head when you have iliac vein bleeding tells me to stop mucking around and just divide the artery in half, open it up, repair the vein, and then join the artery back together, or put your graft in end to end.
Absolutely, it's got me out of trouble on several occasions.
Excellent. I'm pleased to know that's a sensible little man then. Noel, did you have anything else that you wanted to add at that point?
No, I think lots of good techniques have been described. They're going back to the management of the renal arteries. I mean, there's several questions I see about cooling and protection. I've never done any of that. It's, I believe, about getting a timely but very secure anastomosis at the proximal end. I always approach these that, while we all have to dig ourselves out of problems and holes and think, for options B and C, if you approach it, I have one bite at this cherry and I'm going to do a really good sound anastomosis. It stands you in good stead. A useful tool I have, if particularly when I want to be close to, but obviously not damaging the renal arteries, is actually a Leahy used very gently is a very good gentle probe for your direction and positioning of the renal artery origin when you are suturing very close to them. So I happily use that.
Excellent.
And I think, time-wise, I mean, again, it is usually something of the order of 15 to 30, 35 minutes, depending on the complexity of the neck and the anastomosis. But most of the time you can easily do it in that. And that's a more than adequate warm ischemia time.
Keith, the one area I differ, I think, with Rachel and Noel is on ligation of the renal vein. With endovascular taking away most of the nice necks, we're left with the horrible scraggy necks, where you might need a clamp above one renal and below the other. I would far rather divide a renal vein early and plan to do that and have a good look at that neck rather than to run into troubles with venous bleeding. And I have seen huge amounts of venous bleeding when I was training from some of my trainees. So I would divide early, look at that I would never reconstruct a renal vein. I used to have big discussions with Peter Lamont in Bristol, who always used to reconstruct a renal vein. But I think if you leave the gonadal in and then you leave the supra renal artery vein in, you have no problems with venous return, and you rarely see further renal impairment postoperatively.
Excellent. They're all great points, and thank you very much. Rachel, have you got further to move on to, or?
Not really. I mean, there's some stuff about post-operative care, but it's fine. We can stop if we've run over time.
There are some other questions which we could just run through.
Yeah, sure.
I think that we've imparted a vast amount so far, for which I'm sure everyone's very grateful. In supportive of a couple of general surgical trainees that have joined us on a regular basis. Do we have any advice for a general surgical trainee if they find themselves alone and inside an abdomen with a ruptured aneurysm? My initial feeling it would be that I'd be surprised if that was a surprise when they'd arrive there with pre-operative CT scanning. I suppose the question is, as we move away from electives, what is your general go-to rapid control of the neck? Are you rapid clamping, or do you use a balloon?
I think if I was a general surgical trainee and I hadn't done an aneurysm repair for a while, I might leave the retroperitoneal undisturbed and call for help immediately. If the aorta was actually actively bleeding at you, then I think that's a difficult problem. So I'm definitely a clamper. I think the trick to ruptured aneurysms is to cut through the hematoma at the neck, put your fingers down onto the aorta because the hematoma has done all the dissection for you, and run your fingers through the soft hematoma, and normally it will take you down to the neck of the aneurysm and you can put a clamp on.
Excellent. Thank you. Can I take you right back to the beginning, Rachel, of the talk in relation? What are your thoughts on pre-operative fitness assessment for open aneurysms? Do all of your patients get CPEX or CPET?
So there's a bit of a divide in our hospital. So I'm very much for the Peter Taylor ilk, where we literally do an up and go test and do 2 flights of stairs. And if they can do that and they're functionally very fit and have got a normal thoracic echo, I'd normally just get on with it. But I do have colleagues at St Thomas's who do CPET for everybody because they say it's predictive of who will survive and who won't. I've definitely operated on patients with a terrible CPET and they survived, and I've definitely operated on patients with a good CPET and they've died. And I as long as they're functionally fit and can do 2 flights of stairs without getting puffed, and can do a pretty good up and go test, I'm fine with that.
That's brilliant. I can always visualise those very stairs, up and down. I've got a very topical question about the consent form and the relevant details about patients taking them away and thinking to decide. But the point of the question is about adding a hospital-acquired COVID risk to the forms at present. I mean, I'd say yes. I definitely would think you'd need to, but we're certainly not up to the point of doing elective open aneurysms as yet. Even in our we have done an aortic case, but not an aneurysm, through our clean pathway. I know we've talked a lot about clean pathways in the Vascular Society, Rachel. Specifically, how has the COVID affected the consent for open aneurysms?
Yeah, so again, we've done some urgent open aneurysm repairs and some urgent explants, but I haven't done any purely elective cases. At the moment, every patient who is going to theatre has to sign a COVID-specific consent form, not because I want to scare them to death, but because I want to make sure that the surgeon is telling them about the risks. There is no doubt that we are seeing a whole raft of complications related to COVID, mainly thrombus related, so with thrombus in SMAs and patients with occluded aortas and occluded IVCs, weirdness. But I mean, if they're on a clean pathway and they've had a COVID negative swab, their risk is relatively low. But I would specifically mention the complications, and I would have that conversation with them because they may elect to not have their aneurysm repair at the moment and wait.
Excellent. Thank you very much. Now, another question relates to SVS guidelines of open aneurysm repair. So with our American cousins, whether or not they stipulate it's a two-man operation, or and whether or not we should be looking at those guidelines or just go with our local trust guidelines. Certainly, the Provision of Vascular Surgery's document talks about dual consultant operating, but very much in a supportive and for the best interest of the patient basis, rather than it being mandatory or a guideline. Rachel, what's your thoughts? And I might ask Mike as well, because I know that you were involved in some guideline writing previously.
So I agree with what Mike said earlier. For me, a straightforward infrarenal open aneurysm repair is not a dual consultant operation. It is a training operation. I think when the complexity hypes up, I think you should really think about it. I think it really does help you as a surgeon. It certainly makes you feel more comfortable, particularly if you're relatively new as a consultant or in your first 5 years. I think you need to gain some confidence, and having a sympathetic colleague there who can, just hold a retractor and be there is actually very good for your confidence building, but also halves the stress at least. And ultimately, this is for the patients. If it makes it safer for them, I'm all for it.
Yeah, that's great. And certainly for those trainees, I think that are just about to come to consult, they don't have necessarily feel if they're all comfortable already doing open aneurysms that they have to get a senior colleague along. But certainly I would recommend that having a senior colleague or mentor present does improve the exposure, because it's very telling the nous of your assistant, and they can certainly make those easy ones, those initial ones, a lot easier. And it's always good to get a good run going on as you start. Last two questions: would we advocate laparostomy in an elective setting? I would have thought yes, if necessary. I've done it rarely. I think specifically about the bigger patient, actually.
I think if you need to, do it, but I have had to do it exceptionally rarely in my career, I have to say. And
someone else asked, would you have an age cut-off for open aneurysm? And rather surprisingly, perhaps it reflects on the modern world, the suggestion cut-off point is 90, which does seem a decade above where that conversation was had when I was a trainee.
So I don't have an age cut-off necessarily, because I think each patient's individual, but I really do think twice about it over the age of 80. I think that you may be a very fit, sprightly 85-year-old, but you won't be once I've cut you. And an open aneurysm repair is a big deal. And so, there are the occasional patients that are exceptions to that. But I think that when you're knocking 80, 85, you have to think really hard about opening someone's abdomen.
Yeah, no, I agree. I did have a bet with a 94-year-old that ruptured once, that if he was still alive when I finished the rupture before him, I'd come back to him. And he certainly was, and he did very well. He was quite rude about my handwriting on the consent form. So I'm going to say thank you very much indeed, Rachel. That's been absolutely fantastic. Thank you very much to panelists. I'm going to just go around the panelists one by one to ask if there are any little final points they'd like to say. Noel, thank you very much indeed. Did you have any parting comment?
No, I think, all the good points have been raised in this topic. It's been excellent, and I'm sure our trainees have gleaned a lot of very useful information.
Excellent. Well, thank you very much indeed for your time. And Mike?
You're on mute, Mike.
Yeah, me, yeah.
There we go. We CPET all of them, but we don't use that to decide whether or not they have their operation. It's part of the package that we use in our decision-making process. The other issue is that the Americans have a huge medical legal difficulty with aneurysms, and they would prefer to have 2 surgeons operating. I would put it to you that not only does it halve the stress to have 2 consultants operating, it probably makes you medically legally immune as well if you have 2 surgeons making that decision. And also, I think a final word is everyone's different. Every patient is different. And we might have protocols and we might have guidelines, but each individual must be treated as that individual, and the same rules that apply to one of your patients won't necessarily apply to the rest of them or another.
That's brilliant, Mike. Thank you very much, Steve. Really good point about the states and the legal situation as well.
Mm-hmm.
Thank you very much indeed for your time. Rachel, thank you so much. That was absolutely fantastic talk. Had you any parting nugget, or should we leave people wanting to come and see you speak again?
No, I've got nothing else to say. I'm sure you're all bored of listening to me, but thank you very much for asking me to speak. It's been a real pleasure.
Oh, excellent. Thank you very much indeed. So I'll say good night to everyone, to the participants. Thank you for staying with us. I know you've all done, and I hope it's really been really beneficial. And we hope to see many of you back again next week. Again, thank you very much indeed. And everyone, good night.
Thank you very much, everyone. Good night. Thanks for watching.